Well, hello, everyone, and welcome to the Tenpenny Files. I'm your host, Dr. Sherri Tenpenny. The Tenpenny Files is not just another podcast. The Tenpenny Files offers daily conversations that are meant to inform and educate, not just entertain. I come prepared and let the discussion unfold naturally with people worth hearing on topics worth exploring. And if it matters to your body, your freedom, or your future, we talk about it here. Each day, we sit down with authors, documentary filmmakers, and independent thinkers whose work challenges mainstream messaging. Our conversations span a wide range of topics, from government, politics, and history, to astronomy, pets, and travel, to food, farming, and fitness, to vaccines, health, and health policy. We often have weekly conversation with authors about faith and biblical principles. My goal is simple: to introduce you to topics that you've never heard about before, or topics you always wish you'd had time to explore, but didn't know where to start. Sound interesting? Then the Tenpenny Files is the place for you. Join me here every day, Monday through Friday at 3 p.m. Eastern Time, as we hear from voices that have often been ignored, silenced, or censored, but truly have something important to say. So before I begin today's episode, I want to invite you to become a Tenpenny Prime member. Prime members receive an exclusive monthly white paper about your body, a recorded presentation, and access to our monthly Ask the Expert masterclass, which are just over the moon and really very good information. To learn more about it, visit primemembership.drtempany.com, learn about our show, and hopefully that you will join us and support what we do. Now, let's get started. Today's conversation is with Dr. Stephen Loyd, chairman of Reach United, a nationally respected leader in addiction medicine and public health policy, to talk about addiction and advanced policies that improve outcomes and reduce stigma. Stephen, welcome so much to the Tenpenny Files. Thank you so much for joining me. It's a pleasure to see you again.
Yeah, thanks, Dr. Tenpenny. Thanks for having me, and it is a pleasure to see you as well.
You know, you've done so much in the area of substance abuse as a general internist, and you have developed all kinds of treatment protocols, policies. What got you so interested in this area of medicine?
Dr. Tenpenny, I got addicted myself. When I was in medical school, and I know you know this, you're very familiar with this. At the end of the third year, you're kind of setting your fourth year rotations on what you want to do. And I promise you, addiction medicine was not on my horizon. I was wanted to be an internal medicine and teaching physician, and in all honesty, I wanted to be the dean of my medical school, and I was on an academic path. But early in my career, I got sidetracked. One day coming home from work, residency back in our day was different than it is now, and was tired, depressed, didn't like my life very much, and opened the glove compartment of my truck on the way home, and there was some Norcos in there from a dental visit. I hadn't taken them, just thrown them in the glove compartment. And I took one out and broke it in half. And remember having this conscious thought, my patients take this stuff. And broke one in half and threw it in my mouth, 2.5 milligrams of hydrocodone. And by the time I got home, suddenly my life was better. I wasn't depressed. My anxiety was gone. I liked my wife better. My kids were better behaved, and nothing had really changed. And that started me on about a 3 to 4 year run of addiction to OxyContin and Xanax. And when I went through that process and got into recovery, and I have been for almost 22 years now, it changed everything. It changed what I wanted to do career wise. It changed my career path. I'm a better husband, father, and so it became my goal to help as many people as I could every day find the path that I found. And that's why I do what I do, and that's the impetus for it. And it's solely from personal use. I had nobody in my family that had this issue. I didn't lose someone. Mine was all personal.
Well, I listened to your talk that you gave in 2024 at the University Club in DC. You said, quote, stigma kills more people than fentanyl. What does
Yeah.
that mean?
Only 1 in 10 people get help that have this issue. It means 9 in 10 are still out there. And if you compare that to diabetes or hypertension, we're not fantastic, but we're 8 to 9 out of 10 at least getting treatment. And so more people are kept out of treatment and die unnecessarily than actual die of the disease of addiction, fully in their fentanyl. Fentanyl is killing people at rates that we've never seen before. We get adulterates into it all the time. But the big issue is, Dr. Tenpenny, is not stepping out and ask for help, because so many people can recover. There's actually more people in active recovery in the United States today than are active addiction, and people don't understand that, and don't realize it. But the stigma plays in there too, because once you get into recovery, You don't want people to know about your past because it may hurt you with a job or it may hurt you with an opportunity that you have coming forward. And so I will, I will stand up all day long and say that the stigma kills more people than the drugs do because people are not at will to or not free to step out and ask for help.
As a director of a national organization and spend a lot of time in public policy, what sorts of things can we move forward to help to mitigate that?
Well, I think we are. I'm in D.C. right now, and yesterday, Secretary Kennedy announced some specifics around the Great American Recovery Act that President Trump signed the order on last week. And if you look at that, Dr. Tenpenny, I mean, to you and I, it's going to make a lot of sense, right? I mean, people need housing, right? They need jobs. You don't you don't just keep feeding them their drug, right? There is trying to prevent disease, and I get that, but they have to have an opportunity to better their life. And we as a country, as rich as we are called biblically to help those who are not as fortunate, right? To those who have been given much, much is expected. And I think that's where we fall, and I really see that's where this administration's going. And so yesterday was a big day. Secretary Kennedy, made specific announcements about it at a meeting here in D.C. around prevention, actually the largest convention around treatment or around prevention in the United States, which is still going on today. And then his cousin, Patrick Kennedy, and him followed that up yesterday afternoon at the National Press Club with even more specifics around it. And so I think we're headed in the right direction. Now, is it fast enough? I think you know the answer to that, like I do, right? Never. It's never going to be fast enough. But I think now we're pulling in the right direction with the right people at the helm, and it needs to be led top down, Dr. Tenpenny.
No, that's really interesting because, Secretary Kennedy, Bobby, I've known Bobby for over 20 years before he was Secretary Kennedy. And I've read his books. I know about his past, his personal history of substance abuse. So to lead the charge on this, he knows firsthand the importance of the recovery. I think that's really great to hear that's happening right now as we speak.
Well, at the very least, it gives him street cred, right?
Yes.
And you could tell it yesterday. I was with multiple people yesterday, and I knew Secretary Kennedy's story. I've been with him a couple of times before, and in all honesty, Dr. Tenpenny, I've been fascinated with his father since I was in high school. And so, when you look at his story, I thought when I first he had a history of substance use. I thought, oh, he had a little spat here or there and got some trouble when he was in school, but that's not it at all. I mean, Secretary Kennedy had an issue with heroin for 14 years, and that's really hard to comprehend, particularly at the time frame that he was using. And to see what he's seen and been through what he's been through, and to be where he is now, leading the charge. I mean, we've never had that. We had a director of ONDCP who was in recovery at one point, but never somebody who is leading a targeted effort nationwide. And I think it means the world. It certainly means the world to those of us in recovery having one of us up there.
That's amazing. I've done some research, knowing that we had this interview coming up about the total economic burden about chronic disease in the US. But substance abuse disorder has historically been treated as a social problem rather than a medical or an economic problem. And the data clearly shows different. Do you think tell us a little bit about that? And based on what you just said about these changes, is that going to change? Are we going to see the light of day?
I think we will. I'm not sure in mine and your lifespans how close we'll get, but I think our children and certainly our grandchildren will see the fruits of this effort. Patrick Kennedy talked about it yesterday, and Congressman Kennedy had his own issues that have been well documented, and he talked about treating it as acute and episodic rather than the chronic disease that it is, and I couldn't agree more. We've been talking about this for a long time. And Dr. Tenpenny, I know who you are. I've listened to you, right? And so when I look at the current treatment system, I scratch my head. If I had any hair, I'd scratch my hair, but I'd scratch my head. It doesn't make sense. It's a revolving door. The financial incentive is actually to keep treating the same person over and over as opposed to looking at the result. And I've known this for some time and I've talked about it, publicly. I want to pay for things that work. In order to do that, you have to measure your results. You can never improve anything you don't measure. And we have to start talking about what is truly evidence based. And I don't mean swag, right? Scientific wild guess, right? I don't mean that. I mean, what is evidence based? What are we trying to do? What are the outcomes we're looking for? And what is the treatment modality that works best for that patient right in front of us to get to that outcome? And there's only there's only a few ways to do that, and we really haven't had the courage to do that nationally. And I can tell you that the treatment world, I think, will push back against this because they like getting paid the money they got paid this year, and if they spent that, then get 5% more next year. And I've never been a fan of that. I want to pay for things that work, that help people find recovery and build their life and become productive citizens and better moms, better dads, better brothers, sisters, better workers, all of those things. And I think this is the path, this is the start that we need.
You know, we need a champion like you for all of healthcare, because healthcare is all of it. It doesn't matter which subdivision of medicine that you talk about, whether it's pediatrics, cardiology, neurology, pulmonary medicine. It's always about make the diagnosis and manage people till their death. It's not about what we can do to improve their health, what we can do for prevention and not get them to be in that position in the first place. So So, Stephen, I wish that we had an entire champion like you for the entire healthcare industry because we really need it. One of the things that you talk a lot about, I've listened to several of your things, is why overdose deaths are still rising despite increased awareness and what interventions save most lives right now.
Well, it's a weird thing. If you and I look at this right now, and we're going to do some drugs, all right? We're at the dope man, and the dope man is selling heroin, and it's got fentanyl in it, and you and I know that. We're not going to buy the fentanyl, right? It kills us, but we're in our right minds, right? We have a reward center that's fully attached to our frontal lobe that gives us insight and judgment, and that's the way we make a decision. Dr. Tenpenny, when you're addicted, in the throes of addiction, and I've been there, you lose access to the frontal lobe of your brain. And the frontal lobe of your brain only matters if you care anything about insight or judgment. If you don't care about those two things, then it don't matter, right? But most of us care about those. So you lose access to that. At the same time, the part of our brain that has been hijacked by the drug, our reward center or limbic system, tells us that we think we've got to have this thing out here or we're going to die. I mean, and I've been right there. I know exactly what that feeling is like. And so now you've got the double-edged sword. I have to have this thing that I think I'm going to die without. And at the same time, I lack insight and judgment to see the consequences of doing this thing that I'm getting ready to do. And I think we can all understand that. And when we take that approach and we understand that, and we understand how long it takes this front part of our brain to come back online, now we can better formulate a treatment approach to get people to those points because you get to about 90 days of no use, about 90 days. The frontal lobe of your brain starts to wake up. You start to make better decisions. But the problem, Dr. Tenpenny, is it takes 2 years for that process to complete itself. And now with fentanyl, so many people die before they can ever get there. And there is where we are. Now, what can we do to change that? I think that we can use data, we can use information that we already have, we can use known outcomes, and we can use technology to better formulate treatment plans for the individual patient. And I believe that, and I believe that we will.
Not only does policy and healthcare and medical care not treat addiction as a chronic addiction, they kind of treat it as a fragmented social issue that only certain segments of America, the thought is that only the lower socioincome people that are homeless and living on the streets have an addiction or a drug problem. And that's really not true at all. Tell us a little bit about what is the real truth about the demographics of addiction.
The demographics, it knows no boundaries. And you know this, and we just talked about Secretary Kennedy. Let's look at his family. I mean, you'd be hard pressed to find a better known and scrutinized family than the Kennedys. And the Kennedy family has been riddled with mental health and substance abuse for generations. And they know it. They talk about it openly. I live in the greater Nashville area, and Williamson County, which is just west of Nashville. I say it's where all the rich people live, but it really is. A lot of country music stars, people in the music industry live there, and you see these kids dying of overdoses in these communities that are very affluent at really the same times and same rates as you see in other parts of town where you said, okay, I would expect it there. So really, Dr. Tenpenny, it doesn't have any bounds. Now, we can talk about deaths of despair and things that contribute to that. And obviously, you've got better hope for recovery on the other side when you have hope of upward economic mobility and a way to build a life and make a living. And I really think that that's where Secretary Kennedy and the national strategy is going right now. Instead of let's just keeping people alive, which, by the way, I'm for, let's give them some hope and opportunity at building a life where they can be productive. And that is also takes on a certain amount of individual responsibility. When I figured out I had addiction, Dr. Tenpenny, it wasn't okay to use drugs anymore, right? I mean, that's a personal power that I have. And I have to take that on me. That's not anybody else's fault. Now, how I got like I am, there were a lot of things out of my control, but it's not an excuse. Once I know that, then now I can take personal responsibility to build my own recovery and be the dad and the granddad and the husband that I need to be.
The recidivism rate, the fallback rate. They get clean. They can go for the 90 days, like you talked about. They can go for the 2 years. Maybe their brain starts, and then something in life happens, and they say, "Well, just this once. I'm just going to take that drink or do that shot or swallow that pill just that once." How frequent is that fallback rate, and what can we do to just stay the gap for that?
It's really high, and it depends on who you look at, and really the key is duration of treatment engagement in the program. And I talk about this, all the time, and I was so glad to hear it yesterday from our leaders. The opposite of addiction is not recovery; it's actually community and relationship. That's the deal, and it's about building resilience. And Dr. Timpine, I've been in recovery for 22 years, and you just said a couple of things that kind of triggered me a little bit. I have those days too, right? I mean, I have those tough days, and for me, I've got this network of people around me that help me during those times more than any other, so that I don't use, right? Instead of picking up, I make a phone call, or I go get coffee with someone. Hey, here's what's going on in my life. Here's what's bothering me. Here's what I'm up against. And when you break that cycle in your brain, then you start to develop these other strategies. You start to gain these other tools to help you build resilience. And the problem that we have right now is treatment is too short. We send somebody away for 28 days and expect them to come back normal. That doesn't happen. It takes 90 days for the frontal lobe to even begin to come back online, 2 years to totally. And you're going to send somebody 28 days. It'd be like me and you sending a patient for hypertension to a 28-day workshop and coming back and telling them they're cured of their hypertension without doing anything else. It doesn't work. And so when you hear this, let's treat it as a chronic disease. And that's exactly the approach we need to take. Then now we can start talking about making these improvements that we need to make, because there's only one predictor of positive long-term outcomes, Dr. Tenpenny, and that's engagement in the program. That's it, right? So the more we can keep people engaged, the better our long-term outcomes.
You mentioned treatment centers, that there are, and most of those treatment centers that people go away to, they're kind of high end. They're for, movie stars and rock stars and musicians and people like that first of all want the anonymity, and second of all can afford it because they're outrageously expensive. I mean, hundreds of thousands of dollars, some of them are. Where can we find some middle ground? First of all, why is that? And second of all, where can we find some middle ground for average Americans that have these problems?
This is what started my whole path to me and you today. When I was in detox, 5-day detox at Vanderbilt University, I was in there with 23 other people, so 24 people on our ward. I was in my mid 30s, the rest of them were in their 20s, and some teenagers. I thought that we would all leave there and go to a treatment facility right after the 5 days of getting the drugs out of our system. And I was there for a day before I realized that one out of those 24 were going to leave there and go to a treatment facility. The rest were going to go back to the street in 5 days. And that one was me. And the reason is I'm a doctor. I cost too much money to make. It's better to rehabilitate me and put me back in my job than it is to make a new me. And so we have two different treatment systems, and we wouldn't stand for this anywhere else. I mean, we wouldn't, but we do with addiction. It's almost like, you deserve this. You behave this way. This is your punishment. And if that worked, I'd be all for it, but it doesn't work. And so you've got these two different treatment systems. If you have money and resources, you get this, which is what I got. And Dr. Tenpenny, I'm still on my aftercare plan 22 years later, just for your information. Okay. 22 years. Everybody else goes back to the street in 5 or 28 days with no tools, without the support system to give them what they're going to need to face life on life's terms. And I can tell you that that's going to fail the vast majority of the time. Now, how much does it fail? It's solely dependent upon the length of that initial treatment. The longer the initial treatment, the better your long term outcomes. And for me, it's really about when that treatment stops. What kind of housing are you going to? What kind of community you're going back into? Are you still surrounding yourself with the same people? If you are, your chances of success are very low. And so when we talk about building community, this is what we're talking about, and we're talking about building it over the long term. So if you look at the specifics of what Secretary Kennedy outlined yesterday, you'll see a lot of what I'm talking about. There's a lot in there about sober living facilities and sober housing. You have to have places that your recovery can grow after you get out of treatment. And a lot of people think without that treatment is fruitless, and won't bear fruit and will be a failure. And I have to tell you that for the most part, I agree with that.
I think that many people have seen pictures. The ones that stick out in my mind that I remember seeing were from the inner streets of Philadelphia. That people that were really strung out on fentanyl, they can barely stand up. They just assume sort of a posture and just stand there for hours. Do people physiologically ever reach a point that they cannot recover?
I used to hear that was the case a lot of times with long-term methamphetamine use. The damage to the brain was so great that they couldn't recover. But in all honesty, Dr. Tenpenny, I haven't found that.
Wow.
I get people in, and I know you've done this in your own practice. I get people come in, and I think this person's going to do well, right? They have resources, they have some education, they have a way to make a living, and they have these things in their life that they're going to do well, and they're dead in 2 weeks. Okay.
Wow.
And I have others come in. I had this one patient back in Newport, Tennessee, little rural area, that he used to walk to the clinic, and it was 5 miles. He was homeless. I mean, he had no chance. That same guy has a job, he has a place to live, and he's married today. How does that happen? Right? And so it's really, really difficult to predict. So it's where it comes in the individualized treatment approach. Right now in addiction treatment, the treatment you get is dependent on where you show up at. And that's the truth, right? Medications prolong life in addiction. We know that. You could go to a place that doesn't believe in medication, and you will never know that there's a drug out there that has a 70% mortality benefit. And I am a fan of faith based treatment and abstinence based treatment. I came from that. I'm a huge fan. But some people need another route, and they never even know that other route exists, and they die. How is that possible? And it's why we talk about using technology to start to identify these things that tells us which treatment path that a patient would be better served on.
Well, speaking of medications, how effective are medications like Suboxone and methadone, naltrexone, in in treating opioid disorders? I mean, I think that naltrexone now is standard of care on EMS and ambulances, and people that live in communities, they just carry it around with them because it works and it works quickly. Like Narcan, works for narcotic overdoses. How effective are Suboxone and methadone and other types of medication treatments?
Well, Narcan has become mainstream, as you just mentioned. And so, now in the old ACLS and BLS protocols that you and I learned back in the day, Annie, you okay, right? Now it's you hit them with Narcan first, right off the bat. And so those drugs are effective. Methadone and buprenorphine used as part of comprehensive treatment programs are game changers. It's the best we have right now. It has a high mortality benefit, around 50 to 70%, and you'd be hard pressed to name many drugs that have a mortality benefit of that. The problem with those two drugs are the stigma that's associated with them, because both of them are opioids. So you tell the average person on the street, "I'm going to use an opioid to treat opioid addiction." They look at you like grown a second head, but it's really the standard of care now. And when you take that and you keep people alive, because you described it beautifully, you get people that can go 6 weeks, 6 months, maybe even 2 years. But then what eventually gets them are cravings. So they're doing what we call white knuckling it, right? And you can white knuckle for a while, but you can't forever. And so the reason that people relapse after that long are cravings, same cravings that you and I have for food when we're hungry and water when we're thirsty. Medication quells those cravings. So if we can quell those cravings, and you've got somebody in a comprehensive treatment program that start to help them deal with their behavioral health issues, start to deal with the big thing I see, which is trauma, adverse childhood experiences, physical, sexual, emotional abuse, and you start to help them work through those things and gain resilience as a tool, it's wonderful. Now, it gets misused. You get people out there running pill mills with this, just like you do everything else. You've got internet companies selling it on the internet, mailing it to PO boxes. I've seen all that, and all of that raises stigma, and it hurts people trying to find recovery.
Wow, well, that is so important about the misconceptions of that, because I do think that a lot of people think, well, it's kind of like making sure people have clean needles. on
Right.
the street. I mean, what does that really do? It may stop down the transmission of HIV or sexually transmitted diseases, but it does nothing to help with the problem. It's just giving them clean needles. And I think there's a lot of misconception about the opioids using for this disorder too. For the general audience that we have here today, we just have a couple of minutes before the break. Tell people about how they actually work and why they are used.
So explain it this way. A lot of people can't relate to using heroin, but they can relate to eating Krispy Kreme donuts. Right, and we know Krispy Kreme donuts have 220 calories and 20 grams of fat. We know that, but they're really good, right? So that part of our brain, it's kind of a yin and yang between our reward system that wants the donut and the insight and judgment of our frontal lobe that says those donuts will cause you to get fat and get in poor shape, right? And we all deal with that, right? And when we see that Krispy Kreme sign, our eyes light up. We get a little stimulation in our brain, and it causes a craving. And the next thing you know, you're turning left into the parking lot and ordering their Krispy Kreme. We can all relate to that. Dr. Tenpenny, the same thing happens in addiction. People relapse because of cravings, those same cravings that you and I have for food and water. The problem with addiction is your craving for that drug is 10 times stronger than your craving is for that food or water. And that's really difficult to overcome. So if you had something that could quell the craving and not cause people to get euphoric, all right, could quell the craving. Now you can deal with that part, getting the needle out of their arm, getting the stem out of their nose, right? Get them free of the drug. Now you have time to actually work on the underlying drivers. As you pointed out earlier, you give somebody a needle, you give them a clean needle. Yeah, you've done some good things. You've decreased their risk of Hep C and HIV. What have you done to help them build a life? What have you done to get them off of that street corner, out of that tent, and using the bathroom on the sidewalks and into a life where you're living life and productive and engaged in your community? And that's always been my problem with it. I'm not against things that prevent those, but you have to tie them to, what the greater good is. Same way with medication. Medication quells cravings, Dr. Tenpenny. It does not get people into recovery. It does not. There's hard work that comes along with that, but we have to keep people alive long enough to engage in that hard work. And then we've got to have the programs that can deliver it specifically for their case.
Wow. What great information we're having here today. But at this point in time, we need to, Stephen, I need you to hold tight on that thought. We need to take a quick break here from our sponsors for AmericaOutloud.news. America Out Loud Talk Radio plays the Tenpenny Files on the iHeartRadio network daily, Monday through Friday at 3 p.m. Eastern. You can listen anywhere in the world by logging into AmericaOutloud.news and using their media player. You can listen to my show and the other people whose platform is on AmericaOutloud.news. And if you've missed any of these great conversations, you can find the Tenpenny Files on Spotify, Pandora, Apple, TuneIn, iHeart Virtual Studio, and on my platforms, drtenpenny.com, drtenpenny.substack.com, and you can find out more about what we do and what we have to offer through drtenpenny.com. Because there are so many great books, documentaries, and incredible thinkers, and so little time to read, watch, and listen, this show is meant to maximize your time and jumpstart your interest. We have a great message coming up from our sponsors. Please take a listen, sit tight. We will be right back with more about addiction, substance abuse, and recovery with Dr. Stephen Loyd. Zeolite is a detox spray. We work specifically with a company called Touchstone Essentials. They are an incredible company. We've been working with them now for several years. And zeolite is a mineral that goes through your body like a one-way basket. It will clean out heavy metals such as arsenic and mercury, aluminum, cadmium, and it hooks onto those metals from a one-way perspective. So once it's bound, it goes out through your urine or your stools and doesn't get redeposited in other places. Everybody needs to have a detox product in their life, and this one is so easy to use and it's so safe. You can take it when you're pregnant, you can take it when you're nursing, you can give it to little children, you can even give it to infants, and quite frankly, I give it to my dog. I actually put a little bit of the zeolite in his water because until we all stop living in a toxic world, we all need to get some of those extra toxicities out. The heavy metals, the persistent organic pollutants, the things that are floating through the air, the different things that we come in touch with in our environment. And we are a big fan of zeolite from Touchstone Essentials. We've been a big fan of their products for several years. Go to drtenpenny.com/detox to get your first bottle of zeolite spray for $50 off.
Well, only when the government bows to the people will America become great again. This is Malcolm Out Loud here. Join me in pushing back against censorship, my fellow Americans. Right at the top of AmericaOutloud.news are the words, many voices, one freedom, united in the First Amendment. Now is our time, my fellow Americans. AmericaOutloud.news, liberty and justice for all.
Well, welcome back, everyone. Today, we're having a conversation with Dr. Stephen Loyd about the horrible substance abuse problem across America and offering solutions for what can be done about it. Now, let me tell you a little bit more about today's guest, Dr. Stephen Loyd. With more than 2 decades of experience as a board-certified internal medicine physician, Dr. Stephen Loyd has also served as an expert witness for the U.S. Attorney's Office, the FBI, and the DEA in cases involving improper prescription of addictive medications. As chairman of Reach United, the organization aims to accelerate progress in communities struggling with addiction with highly effective, innovative approaches and promote the adoption of proven policy templates. Dr. Loyd has served as medical director for numerous addiction treatment programs in Tennessee. His personal experience and professional insights have helped shape the characters in the best-selling book and the Hulu series Dope Sick, which was based on his life. Dr. Stephen, welcome back to the program. How serious really is the fentanyl crisis in the U.S. right now compared to past drug epidemics?
It's the worst that we've ever had. We've really had three opioid epidemics in the United States. The first one after the Civil War, and the most significant one before the current one was in the 70s, but never as widespread. Dr. Tenpenny, pain pills, were prescribed widely. Usually when you're talking about heroin, you're talking about inner city issues, not rural areas. Pain pills changed all that. Then when we got serious about cutting down on the number of pain pills and educating doctors and providers about proper prescribing and stuff that I've been involved in, we did not treat the people who were already out there, who were already at risk, and they simply switched from very high cost pain medication that you have to get from a doctor's office or off the street, very expensive, to very cheap heroin. And it was black tar heroin, powder heroin coming, across the border, in the southern border mainly, but really both borders, manufactured in Mexico. It's been well documented. It's not telling anybody anything they don't know. But what happened a few years into that was it started to get adulterated with fentanyl. And I don't know about you, Dr. Tenpenny. When I first heard about fentanyl, I thought we were talking about patches or, stuff that we'd used in the hospital and anesthesia, right? But that's not what we're talking about here. We're talking about powder fentanyl that's made clandestinely in China. And for the longest time, China didn't even have it scheduled. And there's some interesting theories around that. I'd like to hear your thoughts on one of these days, because it's killing America's protectors, right? The age group you're looking at is really America's protectors in that 18 to 34 category. And so this really cheap fentanyl, which is really pennies, you don't have a problem with transport, because if you're going to transport kilos of cocaine, you need an airplane, a boat, right? Something. If you're going to transport fentanyl, you need a pocket in the front of your pants, right? Because it's so potent, a grain of it can kill you the size of a grain of salt. And so that gets adulterated into our supply. And Dr. Tenpenny, there's a lot of people out there that die every day that never know they're using fentanyl. I dealt with a group of overdoses down south of Nashville a couple of years ago, and wanted me to come down to the hospital. They had 5 people overdose, and they told me they overdosed on methamphetamine. And I'm thinking about that, and it doesn't make sense to me, right? Methamphetamine is a stimulant, maybe heart issues, heart arrhythmias, but not respiratory depression and coma, right? And so when I got there, I asked to see the drug screens. Well, they had used immunoassay cups, which do not pick up reliably synthetic opioids, such as fentanyl. And so they were all negative. But every one of those patients, when they woke up, told me that they were using fentanyl. It was adulterated in the methamphetamine. Some of them knew it, some of them didn't. And so it's the biggest crisis we've ever had. It's the most deadly crisis we've ever had. The good news is the overdose numbers are starting to come down, and that is cause for celebration.
I had a gentleman on my former podcast one point in time that he had developed a stick, it looked almost like a urine dipstick, but you could wipe it on your clothes. You could do anything that could pick up these traces of fentanyl. And he was trying to get that introduced at the border. Do you know about that? And I have lost track with him of how, and he had told me about that he went to like marches and things like that with parents, and had met parents who'd lost 2 and 3 children to
Yeah.
fentanyl overdoses. Did that ever take off? Do you know what I'm speaking about?
I do, and it has. And when you're using it, when people are using it who I use the word right mind. I don't mean that, but I mean a normally functioning brain. When you use it like that, then there's great utility. And yes, those things are in use. The problem is if you're a user and you're using heroin, right? You're shooting heroin. You think you're going to die unless you have that, right? And that is the main focus of every minute of every day. I promise you, Dr. Tenpenny. You can tell me about your kids. You can tell me about your family. No, it's that. Okay. Now, if you're using that and you come up on a source here and you need it and you use that fentanyl test strip and it's positive, a normal person would say, don't use that. But as I explained to you earlier, you lack that insight and judgment. And the only thing you care about is satisfying this need you have out here that you think you're going to die without. And so this is a case where your lizard brain overwhelms your thinking brain, right? And you use anyway. And so it's got limited utility there, but it's still useful, very useful. And I advocate for fentanyl test strips. I will tell you this. I have had drug dealers and a lot of things I've learned about drugs, I learned from dope dealers. I mean, who else would you learn from? And I've had dealers tell me that they can't sell the heroin that they've got if it doesn't have fentanyl in it because people want that, right? Again, that lack of insight and judgment, the lack of understanding that, hey, 1 grain of this can kill me. It doesn't matter. That's how powerful this urge to use is that overwhelms the thinking part of our brain. But it's a long answer to a short question. The answer is yes, they did take off and they are in use today and pretty widespread use, actually.
From an addiction standpoint, do these different drugs that people use, whether they're hydroxycodone, whether they're heroin, whether they're fentanyl, do they give the user a different sensation, a different type of high, or is it all pretty much the same and just a matter of intensity?
Again, it's going to vary person to person, right? We have our different ways of reacting things, but fentanyl is very powerful, right? I mean, you'd be hard pressed to name many opioids more powerful. There's analogs of fentanyl that are multiple times more powerful than heroin and morphine, and so the high can be more intense. But a lot of times, Dr. Tenpenny, particularly as you become habituated to these drugs, it's not about high. It's not about the euphoria. It's about not hurting. Right. It's about not feeling. It's about not being sick. And that's where I was at the end of my use. I was so beat. I knew I was dying. I wanted to quit worse than anything in the world. I couldn't figure out how. I thought I was going to lose my medical license. And, yet I had to have this or I was so sick I couldn't get through my day. And so at the end, it's really about just trying to not feel and not be sick.
When you mentioned about that it's only a tiny little bit and it comes from China, there's been a lot of concern recently in some of the circles I've been working with about the fact that MREs are food for our military, these little packets that for the audience, the little packets that the military takes on the battlefield because they really don't have a kitchen there. So they've got like a daily allotment of calories. And many of those are now made in China. And there's really a concern about contamination of what the Chinese might be trying to do to our own military. Have you ventured into that area? Are you talking with people about that?
I haven't, it's not my area of expertise, but I can tell you, and because the one thing I have learned over the last 6 years is to keep my mind open. Okay. It just have. And so when I first started hearing about this, I may have downplayed it a little bit, but I have a friend named David Roush, who is the head of the Tennessee Bureau of Investigation. And I've worked with him in this field for a long time, and very few people I respect more than David. And he is a cop. Okay. He is a lawman. And he's the one that first turned me on to this. And I'm going to listen to David because I love and respect him. And Dr. Tenpenny, I think it's a possibility. I don't put it outside the realm of possible. And I think it's possible that it's actually coordinated from the highest levels. I mean, if you look at who's dying in the United States, now it affects all age groups, but it's that 18 to 34 range. And David talked about that because these are traditionally America's protectors. All right. These are our draft eligible folks. And hopefully we never need that again. But I don't discount that at all.
That's scary. Well,
Oh,
let's change gears a little bit. Let's just change gears a little bit, Stephen, and talk about CareNet.
yeah.
What is it, and what excites you about finally treating addictions with evidence? Tell us about CareNet.
Well, first of all, I want you to know I don't make any money from this. I'm not financially attached to it. I don't have stock, none of that stuff. So in my work with Reach United, we basically scour the country and looking for what works. Right? What are the advancements? And I don't sit in an office. I go look at it. Right? When I go to a jail or a prison, I don't read what they're supposed to be doing there. I go to that jail or prison. And so a while back, I ran across CareNet. Had no idea what it was, but I've been really interested in how to use artificial intelligence, machine learning, to better address the problem of addiction. And when I learned about CareNet, I was like, oh my goodness, because I know this. I know that when you walk into a treatment center, no matter where it is, you get the treatment that they provide, not necessarily the treatment that's right for you. And when I talk about that, because I know you're a prevention person, I'm talking about looking at the total Dr. Tenpenny. I'm talking about looking at her genetics, her background, her mental health history, her medical history, her gut flora. I mean, you can think of 100 different parameters here that matter. The problem with looking at these parameters and looking at outcomes based on treatment is they're all siloed in EMRs that don't talk to electronic medical records that don't talk to each other, even within the same hospital sometimes, right? And there's a further problem in the fact that it's HIPAA protected. So you have to somehow get that data out and go through IRBs for every single and institutional review boards for every single one of those. What CareNet does, it's like if you had a project, and that project involved you reading library books, and the library books were all in a different library. You'd have to go in and you couldn't check them out, so you'd have to go in the library, read the book, retain that knowledge in here, and leave the book there. That's what CareNet does. It goes into these individual data sources all around with a question, finds the answer to that question within that data, de-identified, pulls it out, and jumps to the next source. And so when you think about the possibilities of what you can do with that, now you can start to identify specific patients with this genotype, with this phenotype, with this series of background issues with regards to social determinants of health and abuse. And you've got known outcomes of people just like them because you're able to collect data on this massive basis and what worked for them, right? Where are they at in their recovery 5 years down the road? Now you can start to match treatment to the actual individualized patient. And if you want to know why I get fired up, that shouldn't be too hard, right? Because right now we take you and we basically roll you up in a ball of spaghetti, sling it up against the wall and see what sticks. And then we say, oh, 3 out of the 30 people I just threw up against that wall got better. Therefore, what we're doing works. And I don't know what to say about that. It's not evidence based. It's not repeatable. And so what CareNet does is gives us a way to mine this data in the formulation of individualized treatment plans for people struggling with addiction. And that's why I get excited about it.
Well, how long has Reach United been using CareNet, and what changes have you seen already?
Well, we haven't been using it because it's just being developed. And so
Mhm.
that's the advocacy right now is to look at pilots around that. And we've got the people lined up to do that. Not me, but the people who develop CareNet. And I think it's really important that you know that that's not my involvement in it. It is not that. My involvement in it is the utility of it and what it can bring to the table. So that's what we're raising awareness about. First of all, you got to understand the things that you and I have talked about for the last, 35, 40 minutes or so, which is addiction. What are our current options? What's our current system look like? And once you understand those, now you start to find things that can start to help you overcome those barriers that prevent people from getting into recovery. And CareNet to me is the one that I think has the most utility of anything that I've seen.
Do you think that they'll expand? Now, other than, researching a little bit for our conversation here and having this discussion with you about CareNet, is this a software program that's going to be used industry wide? I mean, are they going to be looking at outcomes for hypertension and diabetes and obesity management and things like that also?
I would certainly hope so. It's where the future is pointing. If you look at this, and you and I are basically from the same generation. We were coming through medical school, and you got into cancer treatment protocols. They were pretty much the same, right? You had a first line agent, and then had chemo, radiation, those kind of things. Now, if you look at cancer treatment protocols, they're individualized right down to your DNA. I mean, it's pretty amazing. So we're talking about doing the same thing for addiction treatment that we've done for cancer treatment in the United States, and it's a great question asked by a doctor, which I would expect, is would this have utility in other areas? Without question. And if you look at our chronic disease burden in the United States, 80% of our healthcare dollars go to treatment of chronic disease, which blows my mind, right? And the reason that CareNet attacked addiction first, because the biggest amount of the chronic disease dollars are actually spent on addiction, more than diabetes, more than hypertension. So yes, I do think it has utility in other areas.
I've read that the overdose death crisis in America is equivalent to a plane crash every single day.
Yeah.
There's like 300 and some people on an average 737.
Yeah.
What if CareNet and your organization reach united, achieve their goals, how much will that be diminished in, say, the next 5 years?
You know, it's so interesting because there's so many things at play. I mean, you can never discount what's happening, in the borders right now. Right. And the potency of fentanyl has gone down. The amount of drugs coming across the border has dropped tremendously. We've got interdiction efforts, which I think are really, really important. People poo-poo those all the times. Law enforcement are our partners. They've kept dangerous drugs out of our country. We need to continue to do so. And so I think it depends a lot on that. And I would think that if we could get a quarter drop over the next 5 years, once you implement something like this, that would be a tremendous success. All right, because there's a way to value a life and the economic value of that life from what you make in an average life and what you put into the tax base. And the truth is, Dr. Tenpenny, it's actually eroding our economy with the number of people that we're losing. And so if you could drop it by a quarter, right, or even say half of that, say 15%, that's a needle mover on every state budget in the United States. And you can think of the areas that it would move the needle on: SNAP, TANF, right? Department of Corrections. I mean, what, 70% of the people behind bars today have a substance use disorder or were using drugs or alcohol at the time of their offense. So the impact, I think, is tremendous, even with a small number of 15 to 25%.
I think that's good. I remember speaking, this was years ago now, to a gal who was a prison social worker. And she was talking to them. And she said some of these cases are so sad that these people will be so strung out on drugs and they either terribly injured someone or even killed someone. And when they get dried out, they don't even remember doing it. And they are not, they're like, I killed someone? Like, really? I really did that? Now, that isn't, the gang members across the board, but there are many just normal people that get strung out on drugs and then do that. So I believe that you're right. I mean, if we could just move that needle just a little bit and help those people, it would just be miraculous at a lot of different levels.
It really would. And it's the thing that I look at, Dr. Tenpenny, because, I've been doing this for 22 years now, but I still have those moments of shame. What if I'd have hurt somebody back then? What would that be like? Luckily for me, I had great nurses and I had wonderful people around me that I love to this day. But the truth is, I'm accountable for that. It doesn't matter the reason. I'm accountable for that. And I think about it. And I think about how lucky that, God was watching over me that I didn't do that. But there are people who have. And this is the other thing. When you hear me talk, and a lot of people hear me talk sometimes and think I'm making excuses for things, I'm not at all. I'm about personal accountability. There are consequences to actions. And unfortunately, I've learned the hard way. I told my wife one time I would love to learn a lesson, Dr. Tenpenny, where I didn't take a fist right to the middle of my face, right? But consequences also teaches things, and so it's a balancing act here, because that person who was high and did that and come out and doesn't remember, there's still a victim on the other end of that. And I don't think we can lose sight of that. And a lot of people I know who are involved in that situation have used that victim as the motivation for how they've lived the rest of their life and tried to make it as positive as they can. And I think that's a good thing, although it doesn't bring that person back.
Tell us a bit about Reach United and your role there and what Reach United is all about, what it's trying to do.
Reach United is all about shining a light out. The opioid abatement dollars are being spent. And the opioid abatement dollars, for our audience, are monies that are coming to states from the lawsuits against industry for the opioid crisis. And so the big one everybody would recognize is Purdue Pharma, but it's also the pharmaceutical distributors, McKesson, Cardinal Health, and AmerisourceBergen, as well as chain pharmacies and some individual doctors and practices across the country. And so what Reach United does is try to shine a light on when this money is misspent on things that are not what you and I have been talking about, but more importantly, shining a light on the things that can make a difference in building a system of care. So the ultimate goal here is to build a system of care that no matter where you touch this system, in your doctor's office, in the hospital after an overdose, in an EMS ambulance, in the criminal justice system, in the jail, in a court, wherever it may be, that you get the help that's right for you. That's the goal, and that's what we do. And so I scour the country, travel every single week in my multitude of jobs, looking at systems of care, looking at things that are working, particularly with regards to housing and criminal justice and reentry that we think we can scale in other states. Because a lot of these places have this money, Dr. Tenpenny, right now, and a lot of counties have this money right now and don't have a clue how to spend it on building this system of care.
That's really amazing. Well, we're coming down, unfortunately, to just the last few minutes of our conversation today, because this has been not only informational and educational, but just delightful to have a conversation with you. What is your take-home message for American citizens that may know about addiction problems or may be experiencing addiction problem themselves? What would you like to leave them with here today?
My tagline, right? Addiction's treatable, treatment works, and people recover. That's true. Dr. Tenpenny, I may come across a little sappy here, but I promise you it's from my heart. I love being in DC. I love looking at our nation's monuments. I love looking at our history. I believe in our country. And this is about community and relationship, and I still believe in Americans. And so, to the audience listening out there, if you're struggling with this, there is help. And there is life on the other side, and you're looking at one. One's talking to Dr. Tenpenny right now. And I assure you that my kids and my grandkids will never see that guy. And what a difference that'll make in the Loyd family going forward. And my dream is that that same route is possible for every American.
How can people get involved with what you're doing, and how can they support the cause? Because this is so important to not only to the individual, but to our entire country.
Well, locally, I'm a local guy. I think solutions are local. I love that. And so locally, find out where the money is coming into your community through your mayor's office or county commissioners and how it's being spent. Because it needs to be spent to build this system of care. If you have someone in your family that is hurting in the state that you're in, there are resources to help them, and they're not what they can be, but they're still there. So always, I leave people with ask for help. It's so important to take that first step and do that, even if you're unsuccessful. And people ask me, how many chances does somebody get? And I don't know of a greater authority than Jesus. So I give the Jesus answer, not 7, not 70, but 70 times 7. And the point's not 490. It's as many as someone needs. And I'm not talking about enabling and that kind of things. I'm talking about when you're ready for help, I'm ready to help guide you to that. You can always check out our website at thereachteam.org and find out what we're into. But I always encourage people to get involved locally with how this money is being spent, because that's how our system will be built. And wherever you happen to live, we want that system to be the one that I described, that no matter where you touch it, people get the help that they need.
Well, Dr. Stephen Loyd, thank you so much for all you do. Thank you for your commitment to people and to America and to making these great changes. It's just been such a delight to have this conversation with you here today. I know it's been enlightening and informational to all of our listeners. So with that, I want to close out with one of my favorite verses from the Bible. I close all of my podcasts with, whether they are live or pre-recorded, which is Romans 12:12. Rejoice in hope, be patient in trouble, and be persistent in prayer. Remember to lean into God, trust Him for everything. He'll never let you down. And I'll see you tomorrow right here on America Out Loud at 3 p.m. Eastern and on iHeartRadio. You can listen anywhere in the world from Out Loud, AmericaOutloud.news, their media player. You can also find out more about me, and you can listen to all the things that we do by going to drtenpenny.com. Spend a little time there. Hover over the tabs, see all the different things that we do and that we are involved with, because there is a lot. So wishing everybody that came, thank you so much for being with us today. Have a great rest of your day, everybody. I'll see you tomorrow or the next time right here on the Tenpenny Files. Goodbye and God bless.